So we'll talk a little bit about renal cell carcinoma. There aren't, between now and in the last year, most of the focus, which I'll touch on, is on these PD-L1 and PD-1 inhibitors. And what I am going to focus on a little bit is some of the work that we're doing in the lab that we consider kind of an advancement and a reflection of what's going on in the scientific community mostly. Again, no financial disclosures, nothing picked up between yesterday and today, unfortunately. We'll talk about just an update of just kind of overall kind of managing renal cell, and really kind of the hot thing. The words you're going to hear now is individualized medicine or tailoring medicine, medical treatment to patients, and of course immunotherapy. We'll briefly cover surgery because there's not a lot going on there. I think probably the biggest thing that we've seen is you'll see a lot of papers and presentations and videos, and we have a little bit of a kind of a resins bowl thing that we're doing a little bit later, and I was going to put some videos in here, but I think it'll make it too long because we'll show some of the advancements in robotics and managing things like the vena cava and all that. But I think we've advanced a lot more in partial nephrectomy, radicals, and cable thrombectomy. Just about any thrombus below the level of hepatics now we manage robotically, but we still do open surgery. Just a couple days ago, I had a lady who had a 7-centimeter mass that had extended up into her atrium, right atrium, and was prolapsing across the tricuspid valve. So there you're going to do a sternotomy and put them on full bypass because there's no way to get that done robotically, no matter what anyone says. We're really trying multimodal therapy for recurrences, and that involves using essentially radiation oncology, where we're using them in cases of pre-op and adjuvant radiotherapy, or even intraoperative for for radicals, nephrectomies that then followed up with a local recurrence. And I think that's underutilized in the community. Now the people, you've seen the debates about partial nephrectomy, and there are people who like to show videos of off-clamp partial nephrectomies and trying to preserve function. The bottom line is that in a 2-kidney model, you don't need to worry so much about ischemia like we used to. You almost like you felt guilty if you let any ischemia go on, or even if you did a nephrectomy. I think the data is pretty clear that in a 2-kidney model, do what you can to preserve function, but don't go out of your way and do something heroic that's going to result in a problem for the patient, because these zero ischemia things that were hot for a few years really had no benefit. And we presented this at the AUA, at the plenary just recently. We talked about thrombectomy. This is probably the debate that you see a lot, and this would be a great debate, I don't know, in the future, because this is debated depending on which camp, and there's really 2 camps on biopsy. How many people here biopsy renal masses? Okay. How many do not biopsy renal masses? Yeah, and I would say that still the vast majority of renal masses are not biopsied. And, I think if you're a believer in ablation, and then biopsy is kind of in your repertoire, I'm not so much a believer in ablation. I've yet to have a biopsy change what I do. I use a biopsy to kind of make a decision on whether not to operate. So a patient who is someone who I'm considering that it's a metastasis or some sort of lymphoma or some other hematologic issue that would encourage me not to do a nephrectomy or a partial nephrectomy. I think the concern from seeding of the tract is pretty much gone. It's just we're not very consistent in all the different centers and pathologic departments of how big the biopsy, what kind of core you take. Is it more of an aspirate, like a cytology? And you can't really trust oncocytoma because you can have oncocytic renal neoplasms. I mean, there's or renal cell carcinoma with oncocytic features, and all of those things have caused problems for us. And so we really just use biopsy if we have someone who, say for example, we're going to give systemic therapy to, and I want to know they're a clear cell or mostly clear cell. But even recently, Dr. Bryce and my colleagues, we've had the issue where a patient was sent to us for a cytoreductive nephrectomy. The biopsy was clear cell carcinoma. We did a radical, and it was a 41-year-old man, and it was sarcomatoid, and he died within a few weeks because it's such a rapidly progressing disease. So it's hard to trust biopsy. And any mass that's so small that I would biopsy and survey, I would probably survey whether I biopsied it or not. And if they're too sick to have surgery, they're probably not going to die from the renal cell carcinoma, so I'm probably not going to treat it with ablation. So that's kind of our conventional wisdom, but there is a lot of support in the urologic community to biopsy. And I think if you've got a reliable method, you've got the right people in pathology, and it really does impact the decision-making that you're doing, then feel free to do it. Keep in mind, it does make a partial nephrectomy slightly harder if you are going to do a procedure. Multimodal therapy for recurrences, like I said, I am seeing that we get patients referred to us for recurrence. Say someone had a radical and then they have a recurrence right at the staple line or the hilum, and they don't have any other metastasis. As we know, renal cell carcinoma is unique that metastasectomy has been well established to be effective in decreasing tumor volume and in curative in quite a few patients, because they kind of select themselves out. They don't show up with mets to the lung and intra-abdominal mets with retroperitoneal lymphadenopathy. They're kind of a localized recurrence. So what we do is they go to our radiation oncology colleagues and they give them pre-op external beam. We then take them to the OR, we resect it, and we do intraoperative radiotherapy for just kind of gross negative margins. Why is that? Because we don't use a lot of radiation at renal cell. Well, we know that radiation actually works quite well for metastasis for renal cell carcinoma, particularly brain mets. It's in the primary that radiation does not work very well. Now, I think if you don't have access to IORT, then you can do external beam. So patients who, for example, their insurance doesn't cover the intraoperative radiotherapy at our institution, we go ahead and give them external beam in the community, and then we will resect them. But here you also want to do, this is the one case where a biopsy is very useful, because if it's clear cell, you might even incorporate systemic therapy, pazopanib or sunitinib in these cases. But I think you should be aggressive for these patients. All right, let's get to kind of the cool part that's a little bit more complex, which is individualizing medicine. So genetics and immunotherapy, we'll talk briefly on sequencing, camels, which are these circulating, we can measure not circulating tumor cells, but macrophages that are a response to the tumor environment, and then CAR T-cell therapy, you may have heard of that, chimeric antigen receptor T-cell therapy, where you can create T-cells from the patients themselves and target their own tumor directly, or target something specific, and I'll show you kind of a project that we have going on. And then, of course, the PD-L1, PD-1 thing, which you'll hear ad nauseum nowadays at just about every meeting that you go to. It's important to know that all cancer is genetic, and I'm going to move a little quickly because there's a lot of slides here, and I know I have limited time. Cancer results from a variety of different mutations, and that happens over time. And it's almost like you're trying to get that perfect Powerball combination, right? All the numbers plus that last one that will end up leading to malignancy. Most cancer is not hereditary, and the vast majority of renal cell carcinoma falls in this environment, which is the somatic mutation, which is some sort of mutation, quite often in the VHL genome, or excuse me, a part of the genome, and we're looking at it. And then, of course, as we know, it's loss of VHL that results in this increased tumor growth, and all of the drugs that we're using target some pathway, whether VEGF or some sort of pathway that leads to increased vascularization. And that's why we see these tumors that are just trying to suck up blood left and right and go up into the vascular system. So, this was one of the most prominent mutations identified in the renal cell carcinoma population. It led to all the drugs that you see that came out in the early 2000s, and had to do with inactivation of the second VHL gene that led to renal cell carcinoma, particularly clear cell. But just loss of VHL function is insufficient. You still need additional mutations that will play a role in the development of this malignancy. We do know that epigenetic modifications will play a role, which is basically these modifications to the histone, and we have a project and a nice, one of my colleagues, Dr. Ho, who's presented here before, has a nice R01 on this particular thing called SETD2, which we'll briefly talk about. But modifications and hypermethylation of a particular area, such as the VHL promoter, can result in altering the biology of renal cell carcinoma, making it either more aggressive or less aggressive. So basically, think of it as the genome isn't just altered specifically in the gene, like losing the gene specifically, but it's just actually an alteration on how that gene is going to be used, promoted, transcribed throughout the process. We've demonstrated this. This is SETD2. This is wild-type renal cell, mutant clear cell carcinoma, and you can see the differences, and this is the SETD2, which we're looking at. These are some other areas that have been identified, and you'll hear about BAP1 also. So these secondary mutations are part of the process that leads to renal cell, and you'll see this. You get your loss of heterozygosity, and then you get your SETD2, you can get BAP1, a variety of one. This is the one we focus on in the lab here. And can they be predictive? Can they be prognostic? A prognostic factor is a characteristic that provides information on the likely outcome of disease. Predictive will tell you, it provides information on the likely benefit from treatment. And that's what's important to us, especially with all these new drugs that are available. So the question is, are they predictive of response to systemic therapy? We know that certain drugs can target the microenvironment, And targeted therapies are going to inhibit some of these pathways that are turned on or off by these mutations, and particularly these secondary epigenetic mutations. So for example, if I order molecular genotyping of clear cell, what can we find? Sometimes we don't find mutation. Sometimes we find mutations, but we can't target therapy at it. Sometimes mutations with targeted therapies aren't even approved or going to be paid for, and we know these drugs are very, very expensive. So the ones we're really looking for are mutations associated with hereditary cancer syndromes, and we'll talk about where we're going to go with that patient population, particularly the young patient that has renal cell carcinoma. But this is the biggest problem, is you can order very expensive sequencing, but you get mutations that are not actionable. I mean, this is kind of, what we're going to get in our report from some of these companies, and it's not really going to change a lot because you can't really figure out what exactly you want to do, or if you have some that are associated with some of these mutations that we can identify in the lab by immunohistochemistry. So histology is the primary determinant of first-line therapy. We know that clear cell is what's going to drive the use of all of these drugs, and it's changed over time. A few years ago, it was if you had variant histology, you used an mTOR inhibitor like everolimus or temsirolimus, something different than a TKI, but it's my understanding from my medical oncology colleagues that now, the party line is everyone's going to get a TKI up front, particularly pazopanib, because it's just a little bit better tolerated. Now the question is, do epigenetic classifications provide prognostic information, that are going to tell us about cancer outcome? Well, what's interesting is you might be aware there's two main prognostic scoring systems that are out there for renal cell carcinoma. The Mayo Sign score, which is just stage, size, grade, and what really makes it different than the UCLA score is necrosis or tumor necrosis, and it's very predictive. And if you think about it, tumor necrosis is just reflective of what? A rapidly growing tumor, because it's essentially outgrowing its blood supply. And it's been demonstrated pretty clearly that the sign score is the most predictive out there on external validation. UCLA score is good as well. And this is what's interesting about all the sequencing and all the companies that are coming out with what we're trying to do. So you've got BAP1 loss of loss of expression. These are the different things we can sequence. But what we found is that the Mayo Sign score is the cheapest, or even if you want to use the USLA index, is the cheapest and most reliable on outcomes. There are advantages to using immunohistochemistry, and it can identify inactivation of certain areas of the tumor and certain proteins, but they're not that cost effective when you compare it to the Mayo Sign score, and particularly less. What's more expensive is genome sequencing. Very expensive, what we're spending. But what we do know is that if we do BAP1 IHC, it is associated with a worse prognosis. We'll keep going, so I'm not going to kill you with this. So the question is, sequencing tumors, can it change what our patients are going to do? How are they going to do? And people asked this yesterday with respect to bladder cancer. I think it was Mike that asked, are we sequencing people up front? And the answer is no. And the reason is that it doesn't change much. And IHC, looking for BAP1, looking for SETD2, might actually be a little bit cheaper than spending thousands of dollars on some sort of foundation medicine sequencing or some other industry sequencing. Here's an example of a 72-year-old female with stage 2 clear cell. They get their sequencing. This is what they find out. Here are all your options. And it's really not going to change what we're going to do for this patient, even if it's a partial or a radical nephrectomy. We do know that we've tried sequencing at a variety of different sites. TCGA is, if everyone's familiar, it's called the Cancer Genome Atlas. It's essentially a national and federally funded approach to coming up with sequencing that is occurring in patients that have annotated samples. Centers are submitting. We submitted patients for bladder cancer, kidney cancer, and prostate cancer, and can come up with these incredible lists of all the different mutations that we're looking for. But an example is that the vast majority are going to be what? VHL, which we all knew already. We'll keep going here. We'll move along here. So remember, the other issue is that kidney cancer is it's a heterogeneous disease. And what we're really looking for that's going to predict treatment is this, clear cell. I mean, we have some type 2 papillaries that have some clinical trials that are out there. There's some translocation tumors. And there really isn't a lot that's available for those patients, short of even hitting them with standard first-line therapy that we use for clear cell. But here's what you need to know in your practice, is at the age of onset, is going to change how you refer these patients for genetic counseling. And these are the hereditary tumors. Basically, your younger patients, and you kind of see where they're presenting. So if you get a 35-year-old or a 40-year-old with a small renal mass, and you decide either to excise it or ablate it, I hope you're going to excise it in a young patient like that, you really need to start thinking about inherited mutations as opposed to somatic mutations. It's going to be linked to a hereditary syndrome. And we see this, I mean, we're not talking about tuberous sclerosis or the young kids that have AMLs, we're talking about clear cell carcinoma in these younger patients. So looking again at age, you kind of see where we're falling, and here's the age of onset for inherited syndromes, and you're going to see this is kind of the number that you're looking for. We're going to move along, the same thing. So here's what's going to be a guide for referral for genetic testing. And in our practice, if they're 45 or younger, we're going to refer them to a genetics counselor. And that's going to actually be helpful in some small percentage of cases where it might change the way you survey that patient with repeated imaging, especially now in the era of where even the guidelines aren't clear how long you're supposed to follow renal cell carcinoma patients. Real quick, this is some work we're working on, which is CAMLs, which are cancer-associated cells that are in the bloodstream. Not only do you have CTCs specifically, which are circulating tumor cells, but you can have response from an inflammatory standpoint. We used a microfiltration assay. Now, there are a variety of different companies that are out there. They basically can filter the blood, and they pick up, theoretically, circulating tumor cells. Hasn't really changed treatment. What we were looking for was specifically circulating cells that are associated with renal cell carcinoma, particularly macrophages. This is just an example of how we can do IHC on them. I'll move quickly. Let me go back. And what we were able to do was we were able to identify taking blood, spiking it in the lab, and then running it with renal cell carcinoma a cell line, and we could reliably pick up the macrophages that are associated with those cancers in the bloodstream or using this technique. And the beauty of it now is we can do it from banked blood. What a lot of people don't realize is that all circulating tumor cells or any flow dynamics in living cancer have to be done with fresh blood. We've come up with a way to bank the blood in such a way that those cells are preserved so that we can now go back and use it as a marker down the road if a patient recurs and see if there's something we can identify when they had the original tumor. CAR T-cell therapy, very exciting. It's the concept of, it's kind of like immunotherapy on steroids. And there's kind of a version of it, if you think about it. You know, Provenge was a version of boosting someone's immune system. We talked about checkpoints. You'll see this slide numerous times. PD-L1 and PD-1 are the things we look at most. These are just the trials. I'm going to run through this very quickly. These are the drugs that are being used mostly, which is nivolumab. Anytime you hear UMAB, it's going to be essentially a PD-L1 or PD-1. These are examples of trials, and you might remember that this particular receptor, CTLA4, or what originally was B7H1, which is really the PD-L1 receptor, was for renal cell carcinoma. And it led to all the things in melanoma and all the other tumors that we're using. These are examples of some of the trials that have been done. You can see the way we've used it in metastatic urothelial cells, and this was touched on yesterday. This is urothelial cell. And then here are trials that have demonstrated the predictive role of PD-L1 expression. And keep in mind that even if they're not PD-L1 positive, they're still going to get treatment with these drugs, because the staining, as we talked about yesterday, is just not reliable. It's depending on which lab you're in, what the temperature of the marker that you're using. So I don't think we're at that point, like with breast cancer, where they'll stain for ER, PR, and even now the androgen receptor to see if these patients are triple negative. It's not going to change treatment. We'll keep moving. So some key points of what we talked about here is that the age of onset for renal cell carcinoma is very important on whether you're going to send them for genetic counseling. Under 46 is going to be key. That's going to drive you to send them to a genetics counselor. And these immune checkpoint blockades are really kind of the new era for renal cell carcinoma. We do know that even PD-L1 negative tumors, particularly even in renal cell carcinoma, are going to still respond to therapy. And getting back to the CAR T-cell therapy, just so you understand what that is essentially taking a patient's own T-cells and priming them to the tumor itself, presenting it with actual antibodies and altering the antibody itself. What we've been doing in the lab is that we actually can take a T-cell and alter the PD-L1 specific, based on what's out there. There's actually the sequencing of PD-L1 out there that's universally available, and we use a virus to transfect it and ultimately target directly. The problem with the PD-L1s and PD-1s that I think Alan touched on yesterday was that people can get a systemic immune response, and I will tell you that we do forget that when they get one, it is dramatic, and it can be significant. You know, we get this impression that they're benign drugs. I mean, they are compared to a lot of other therapies we use, but you need to have a way of turning off the immune system. With these created T cells, we have a pathway where it's like a light switch. You give them another drug which turns off the activation of that cell within a few hours, and that's what we're trying to come up with. Combining that with the camels, which are the circulating tumor-associated or cancer-associated macrophages and lymphocytes, we are able to hopefully come up with a combination of evaluating them with camels and then creating a CAR T-cell treatment specific to each patient. And I can tell you it's not going to be cheap.